Okay, so presenting on behalf of Dr. Sarika, how do I move it forward? Huh? Okay, so I'll just take you through the history of capsulotomy. Is not working? Okay. So let's see how the role of capsular opening and the means of achieving it has changed over time. From a roughly made tear to allow access to the nucleus for its extraction. Can we have this sound off, please? Sound. Outside? Okay. Through the creation of more regular openings to allow support for intraocular lenses, to continuous circular tears to help contain the IOL, and now precision in size and location with laser and other technologies, to the use of the capsulotomy to hold the IOL. There has been a long journey of capsulotomy. And this is the man we can owe a lot to. And this is Jacques Daviel. And he was the first to really start cataract surgery in the world. He pioneered the idea of removing the cataract from the eye in 1947, 200 years before our country became independent, by opening the capsule and expressing the nucleus. These were his set of instruments at that time, more than 270 years before. But as usual, the medical establishment in Britain was skeptical to anything new, and this was Dr. Pott who did not accept that, and they stuck on to couching. Lots of people don't know what couching was all about. We have always said a lot that we have come a long way from couching. So I thought I'll just show you what was couching as a matter of interest. So this is couching, where you pushed a needle from close to the limbus, and this is couching happening in place, and then you move this needle sideways and knock the lens downwards. This is the couching doctor who is doing the couching. Well, at least it was minimally invasive. Then Harold Ridley came on the scene with his first lens, and he used the Von Graf's technique. And this was the first video recorded for a cataract surgery with an intraocular lens by Dr. Harold Ridley. So this is the first lens going within the eye in the history of ophthalmology. And he did suture it up. Welcome, Dr. Vasavda, please. Sir. Then it was Charles Kilman. In 1960, he suggested a new kind of extracapsular surgery. It was called Phacoemulsification. And this is his video of the first phacoemulsification, doing what we know as the Christmas tree capsulotomy. So with the capsulotome, he held the capsule, pulled it out, and then cut it. So it was like a Christmas tree. That was the first Christmas tree in the world. And then came a major change. The CCC, continuous curvilinear Capsulorhexis. Many people have wondered from where this term came in, continuous, curvilinear, and Capsulorhexis. Actually, what happened was, there were three men who gave the names of this capsular opening for their various approaches, and they were working almost at the same time. And these three men were Dr. Gimbel, who said this is continuous, Dr. Shimizu, who said this is curvilinear, and Dr. Newhan, who said this is a Capsulorhexis. So they had these three techniques which were essentially similar but with different names. So the American Society decided to call it CCC, honoring the three doctors. So this is a rare peep into how this CCC was developed by the three stalwarts. Moving on, then came the Rexis with a Trotta's forceps way back in 1988, and with this he made capsulotomy more controllable for many surgeons. We are very familiar with the Trotta's forceps. However, there was still an issue that CCC required a good red reflex to be reliable in certain situations like the white cataract. So this was the doctor who introduced the fluorescein stain for the first time and then did a Capsulorhexis. This was way back in 1999. And then one step was, how can we make the CCC more precise? And here one gentleman had a ring inside the eye, along which he did the Capsulorhexis, and this was the Tagignan ring, and the other person had a corneal marker on the outside. And then came the Varion, the present day marking system on the basis of which we can control the size of the Rexis. Thank you so much. So that was a little bit about Rexis, the history, the past. And I'll request Dr. Shroff to give his presentation on the first part of modern day Capsulorhexis, that is the Capsulorhexis with the needle.
Thank you, sir. I would like to thank you for the opportunity to present at this instruction course, and I would like to thank the AIOC as well for the opportunity. So I'll be talking on manual capsulotomy, and a large part of my talk, I think sir has already covered in the beginning. So I was just going to mention the evolution of capsulotomy, right down from Jacques Daviel to Kelman with the Christmas tree, and Kratz with the can opener type of capsulotomy. Again, the same repetition of how the name continuous circular Capsulorhexis came into being for the three gentlemen, Gimbel, Newhan, and Shimizu. So what is an ideal Capsulorhexis? It should be about 5 to 5.5 mm in diameter. It should be continuous. It should be central. And it should have a good overlap of the optic margin. Now, the advantage for Capsulorhexis were that phacoemulsification could be performed easily. There was less risk of radial tears extending, which could have happened with the can opener technique. The IOL was centered symmetrically inside the bag, and the anterior capsule could provide support for implantation of an IOL in case of a PC rent for a sulcus implantation of an IOL. Like sir said, one of the prerequisites is a well-dilated pupil, a good red reflex, which can be attained by maneuvering the globe. Removing the lipid layer, you can add viscoelastic onto the surface of the cornea, which removes annoying reflexes. So cohesive viscoelastics like Helon again help us to maintain a closed, well-formed chamber and helped us to improve the consistency of making a Capsulorhexis. The instruments, one is a cystitome, which is just bending a 26 gauge needle. A 70-degree bend gives a good grip and visualization for doing the capsulotomy. The Trotta forceps, like sir already mentioned, it helped for attaining better control. However, it was a little bulky. It tended to shallow the AC, and you would require a high viscosity viscoelastic while using it. Newer modifications include the 23 gauge forceps, which can be used from the side port in cases of intumescent cataracts, pediatric cataracts, where the capsule is quite elastic, shallow AC, and when you have to do a Rexis retrieval. So this is just the technique, just a video of a normal Rexis that we perform, 2 to 3 millimeters outwards from the center. A puncture is made. Then you have to balance the tearing and the shearing forces, basically directing the flap. Once you raise a flap on top of the flap, direct it towards the center and keep moving in a circular manner using the iris as a reference plane. There are a couple of difficulties you can have. One is with a bunching up of the Rexis in the subincisional area, so you should always reposition, make sure that the flap is folded well, and then you can get a clearer visualization as demonstrated in this video to complete the Rexis, and then pull forwards towards the center again, just completing the Rexis. Another difficulty with the subincisional area, it may be good to try and swing past that in one single go so that there's no bunching up of the Rexis. So these are the advantages which already we've mentioned. Now, discussing the pros and cons, I thought I'd just show a study that we did looking at the ELP comparing flax and the manual Rexis done by a single surgeon at our center. So ELP is one of the most important determinants for whether the lens is going to maintain its position well and the outcome of the surgery. So ELP is defined as the distance between the anterior surface of the cornea to the principal plane of the IOL. And it's the most common source of error in IOL calculation. Now, there are a lot of factors related to it. What we're going to be stressing on is the Capsulorhexis size, centration, shape, and continuity. So ELP has a major impact on refractive power post-IOL implantation. Post-op refraction is a major determinant for patient satisfaction, especially with multifocal torics and other premium IOLs. And about different studies say between 10 and 20% of patients have more than a diopter post-surgery of a refractive error. Now, capsulotomy is closely related to the effective lens position. A small Rexis has been linked to capsular fibrosis. The lens shifts posteriorly and it's a hyperopic shift. A large capsular Rexis tends to cause a myopic shift. So a 1 mm difference in the IOL position may result in approximately 1.25 diopters change in the refractive error. So we compared MICS and flax. We did about 100 eyes with grade 2 to 4 cataracts. We looked at various other parameters as well, but I'm going to stress on what we found in terms of the ELP. So the surgery itself was performed with the Centurion system. The IOL model was the Alcon SN6 CWS. And cumulative dissipated energy, volume of fluid used, UCVA, BCVA, refractive spherical equivalent, CCT, and ECD were noted. This is how we looked at the ELP, which is the AC depth, looking at the IOL Master 700 plus half the IOL thickness from the IOL Master 700. So the difference between the predictive and the achieved ELP was analyzed. Tilt was assessed by measuring the internal coma. And we looked at, basically, how did we look at centration? We took the Purkinje reflex of the IOL. This is imaging software we use. We looked at best fitting circles for the limbus, for the Capsulorhexis edge, and for the IOL optic, assuming that these pixels were converted to millimeters based on the fact that the IOL optic diameter is around 6 millimeters. And we looked at the CCC size, CCC to limbus distance, IOL to CCC distance, and IOL to the limbus distance. So what we found was fairly interesting, that the achieved and predicted ELP was comparable in the flax and MICS group. There was no significant difference. Even the mean size of the Rexis was almost the same, 4.96 versus 4.94. However, there's a greater variation. The coefficient of variance was greater in the MICS versus the flax group. Decentration with respect to the limbus and the IOL with respect to CCC were comparable in both groups, and tilt was also comparable in the two groups. So flax does produce a perfectly circular, well-centered Rexis. This, however, does not translate it into a more predictable ELP or improved visual outcomes. IOL and CCC centration with respect to limbus is comparable in both groups, and even the ELP and tilt were comparable. So in the hands of an experienced surgeon, the final results are comparable. Additional benefits of a manual Rexis: there's no investment cost, there's no instrument-related maintenance cost, surgical workflow is not affected, and no cost of upkeep of the machine. Now these are a few electron microscopy images showing the comparison between what is the Femto, the manual, and the Zepto Rexis edges. And you can see that the Femto has a slightly more ragged edge compared to the manual. And I think Zepto Sir will cover, so I'm not going to talk much about that. There are some drawbacks to a manual Rexis. Like I mentioned earlier, this is an example of an Argentina flag sign where the capsule splits open. The Rexis can extend as is seen in this video. I'll just skip it a little forward. As you can see here, while tearing the Rexis, it just suddenly kind of goes out because of the intralentricular and the pressure inside the lens because of the intumescentness of the cataract, and then a rescue has to be recommended. Now this is a way to get around that. You can either decompress the capsule with a 26 gauge or a 30 gauge needle, take out some of the fluid, and then proceed to a Rexis. Use a good cohesive viscoelastic, use a 23 gauge forceps from the side port, and then go ahead and complete the Rexis in this manner in a controlled way. Always making sure to grab at the edge and then pull towards the center. Other things you can do in hypermature and other hypermature cataracts is to make a smaller Rexis first and then spiral it out later, or even after completing the phacoemulsification, make cuts on the Rexis and enlarge the size to ensure a good optic cover is attained. So this is just completing this Rexis with the 23 gauge forceps, which is shown over here, and you get a relatively good round Rexis. So the drawback of a manual Rexis basically in these intumescent and hypermature cataracts or in cataracts with a shallow anterior chamber, the conclusion is that yes, all technologies have their role to play. Just now I use both the Femto and the Zepto as well. But at the end of the day, we are all surgeons and we should know how to get away with when we don't have that technology available. So a manual Rexis, knowing how to do it well, is extremely important. Thank you.
उसको डाल देना है Zepto वाला. हाँ. Okay, that was Rushad, and the message that came out loud and clear was that still the basis of all capsulotomy is a needle capsulotomy or a forceps capsulotomy, and still probably almost all, that means very few percentage, could be less than 1%, are using other techniques for capsulotomy. Some techniques have a definite advantage. I would be highlighting some advantages of the Zepto. Dr. Vasavada would be highlighting the advantages of the Femtosecond Laser. And then we could look at some modern options and then decide what is the best way to go in for a capsulotomy. So, in a wide turgid cataract, this was a limitation in a needle capsulotomy where you saw the Argentina by Dr. Shroff. And so what we are doing is, we are going in straight for the Zepto technique. And let me tell you, the Zepto system works through a micro incision, which by definition is about 2.2 millimeters or less. And this is the Zepto on the underside. There's a cusp, and you see this metal ring. This is called the nitinol ring. And the property of the nitinol ring is that it has an excellent memory. So you can stretch it, it goes into the eye, and when you pull back the plunger, it comes back to its original shape. So now this console, this tubing system is attached to a console, and the first step is vacuum, where there's a suction. The second step is fire, which we have done now and made the capsulotomy in 4 microseconds, and then you take it out. You release and you take it out. Now see this edge of the capsulotomy piece, which is in the center. It is curled on itself. It's curled upwards. Both on the on the capsule side and both on the torn piece side. Both are curled, and this curl and the fact that collagen 4 gets converted into amorphous collagen gives this capsulotomy a unique strength. And just imagine, at one place in this same white cataract, we were afraid that the tear might run out, and now we are playing with it and stretching it away. Such a contrast this technology has given us. So just looking at some pictures which gives us a better understanding of what is happening. When the edge of the tear, if you look at the edge of the tear, it turns up on itself, it curls up. And the functional edge is now not the cut edge, this is the cut edge. The functional edge is this rounded edge. And if you look at the electron microscopy, this is the cut edge. This is the functional edge. It is turned up like this. And this functional edge is kind of doubling up there. For example, if you take a thin foil and double it up and try to tear it, it will be much more difficult to tear it. If there is a foil which is just single and you tear it, it will be much easier to, and much less tearing force is required to tear it. So now this thickness is almost 20 microns vis-a-vis normal Rexis, which is about 10 microns thickness anterior capsule, and this is comparing it to the CCC edge margin. This is the CCC edge margin functional, this is the Zepto edge margin. And this is showing, look at the right side image, right here is in cadaveric eyes, the Zepto working here and making a capsulotomy, and in the same paired human eyes, cadaveric, this is the Rexis forceps making a capsulotomy. So capsulotomy made here, capsulotomy in the process of being made here. Now the idea of this paired cadaveric human eyes was to do a real experimental check on what is the true strength of this Rexis edge. So after making this Rexis, there was this testing system which held the Rexis and was pulling it, and in a normal CCC or a needle Rexis, the Rexis gave way at a force of 16 millinewtons, whereas in a Zepto Rexis, it gave way at a force of 60 millinewtons, almost three and a half times the strength it was able to absorb to reach that tearing level. And this was the comparison between Zepto and Femtosecond Laser. Somehow Zepto faced a better outcome compared to Femtosecond Laser, almost twice the strength. Even Zepto with the CCC shows there is a marked difference in the capsule edge strength. So, and these are the literature supporting the same fact. And now we looked at some other options for Zepto, and we found it to be very useful in a hard brown grade 5 cataract, where our requirement was that the capsule should be large, which is we are getting about 5.25 or 5.5. That is one basic requirement of the phaco. You should do a large Rexis, and you should have a strong Rexis, because in these hard brown cataracts, the anterior capsule is thin and has a very strong tendency to tear. So we get both the advantages of a larger Rexis and a stronger Rexis in a hard brown cataract, and we can comfortably do this. Then we were looking at using Zepto in premium IOLs. That means the toric IOLs and the multifocal IOLs. Why? Because here we want to be doubly sure that the Rexis does not give way. Because if the Rexis gives way and you have promised the patient a multifocal or a toric, you have to stop that process and revert to a monofocal, probably a 3-piece IOL. So you don't want that situation to happen, then probably Zepto is a good option to do premium IOLs. Then we used Zepto in small pupils. And this pupil, which is about 3 or 3.5 millimeters, without the help of pupil expanders, we could still do a capsulotomy of 5.25 millimeters, even though it was a blind capsulotomy that we were not exactly seeing where it was, but still we were sure that we are getting the right size and the right centration of a capsulotomy. So this is how the capsulotomy looked after I put in a malignant ring to see this capsulotomy. Perfect looking capsulotomy under a small pupil. And then, but still, why go blind when we can expand the pupil before doing a capsulotomy? So I put the B-hex ring and then I expanded the pupil and did a capsulotomy. I prefer the B-hex to the malignant because it's a thinner ring. It occupies less space and it gives me a better movement within the eye with such a thin ring. And this is a 5.25 millimeter size of a pupil I get with the B-hex ring, and my capsulotomy is also almost 5.25. So a B-hex ring matches my need for a Zepto capsulotomy size. The capsulotomy can be very useful when you have anterior capsular fibrosis. And here's one situation where there was an anterior capsular fibrosis, and I could have done it with a needle, but I found doing it with the Zepto very useful. Probably if the anterior capsular fibrosis was even more bigger in size and reaching up to the Rexis edge, I could have managed it with this Zepto capsulotomy. And another situation where I found it very useful was in a subluxated cataract. Some people say it should not be done in a subluxated cataract because you may tear the zonules, but I think you can hold the capsule, bring the cataract to the center, and then do a Rexis in a fraction of a second, that means 4 milliseconds. You get just the right centration and just the right size for a capsulotomy. But it does not mean everything is good with the Zepto. There can be situations which are not really defined, but there could be problems. Here is one such situation in a white turgid cataract. I was doing a Zepto and see the problem I faced. It did not give a complete cut, and there was a capsular tag attached to one edge of the Rexis margin. So it is not that there is never, you always get a 100% free cap. There could be problem, but this is rare. I just got 2 cases so far in my series of about 200, but it is manageable. Thank you so much. And with this, I invite Dr. Vasam to enlighten us about the capsulotomy with the Femtosecond Laser. After this, and then there's just one for modern techniques. One more. Yeah.
Thank you. Thank you for your attendance here. I hope you had your lunch. I didn't have it. I do receive research grants from Alcon Laboratories, but has maybe some interest that I'm using the machine and going to show that machine which I use from that company, but otherwise nothing specific. I think it's been recognized very well, and I endorse that it's very easy to perform, but the best part is the predictability. And it is a predictability, in other words, you should be able to reproduce it every time you want to do a procedure. And that differentiates a surgeon from other people and the technology from other technique and so on. And of course, it has to be quite precise. So that's an appeal. Now, we do know, and I think it's been accepted, that the value of flex, femtosecond assisted cataract surgery, is okay in the spatial situations. And I will go through that spatial situation. But not very many understand that it is very useful in routine cataract also. Although the routine cataract could be different definition of routine in your particular geography than mine, but whatever the routine cataract is, if it works predictably well, that's what you want, the technology, the skill, and whatever you have. And that's where I think the femtosecond flex capsulotomy has an advantage that is going to work every time. And then other thing is that you can combine some other techniques like pre-chopper in the flex. This is not related to the Capsulorhexis, but and you can do perhaps with the with some other thing, but with the devoted machine like Zepto and others, you can't address that. So I think this is one more advantage of flex and not Rexis, that you can combine pre-chopper and whatever all other technique is, because what we are looking for is the consistency or predictability. We did a study before we decided to buy the lens sets I had. I was late to buy this machine. Probably I was 17th or something like that in India, and 2.5 years later of the innovation that I bought this machine. And before we wanted to understand how valuable it is. So I did consecutive 100 Rexes, and I could not complete in one continuous. My junior consultants did 94 out of 100, and my senior fellow, which were, year and a half, they could do an 89. And that gave us a bell to us that, why not 100%? So I can vow that these flex-assisted Rexes, whichever the company you have, will be able to produce 100% in your routine cataracts. I'm convinced. Question is the money for which you need to pay for this 100%, or that remaining 1 or 2%. So clinical and optical significance of centric Rexis is understood, although I must say that the Rexis centration is not perfect in all of these flex. It's not terribly better than Zepto or other things probably, but maybe better than manual in some hands. Now, the whole philosophy of this femtosecond laser assisted is good because it is done without opening the eye. So when I talk to my patient, I generally don't canvas for this procedure, but I do about 40% or more of cataract surgery by using this technology. And if I'm putting a corner, what would you say? I would say this is safe, a little bit safer compared to any other technique you have, because the eye is not open and these steps are done with the precision and almost 100%. So that sort of thing is good for a surgeon. And I see I have a variable caliber of surgeons. I have fellows, I have a junior consultant, my children. Their confidence has boosted up so much because when they sit on the chair, the Rexis is already performed and the division process is already assisted to some extent. So that translates into the overall confidence, which will give a good control on the performance of the remaining part of the cataract surgery. And I'm convinced that this is a great way to do this. The real bugbear is the money, and I have no answer to that. So those who are fortunate to have enough resources, consider that LensX or the Femto Flex induced. And you can certainly now go for Zepto, because wonderful cases I saw just now. So these are all similar things like what you saw earlier, and the only difference is that the bridges would happen in this also. But these bridges will be smaller and more easily manageable compared to some other techniques. But they can occur there. This kind of thing is not very common, that it will truly floats in the chamber, although it is totally detached. It doesn't literally get lifted up every time. But this is one of the rare or uncommon cases that happens there. And then you need to stain that capsule to see in case there are microbridges. And imagine there are microbridges and do that. Although this is a totally detached thing, because the capsules are very fragile, and trypan itself can also make it a little more fragile. And trypan issue, I just got a recent knowledge. A guy from UK told me, Sanjay, that trypan are being questioned now beyond the limit concentration or time, because it's found to be carcinogenic in the long run. So I don't want to scare you, and but there are surgeons who do hydrodissections, and they use trypan blue very generously in retina and not trypan blue, trypan blue, yes, in the cataract surgery. Retina, they use the other one. But so in other words, these can make it, and microvies are more easy to handle than the big ones. And small pupil, there is a limit, of course, and you can do with any pupil, but then obviously you will end up with capsular fibrosis, and you will have to use the retractors. Some people use Malugning ring or Bhattacharya ring or somebody, and then do Rexis. But I just do not use those things, and I do not perform that Rexis if the pupil is smaller than what you're seeing here. But if it is that kind, this is not bad at all, and you can really do it well. And then what you need is to just pick it up with that, and you can achieve a good performance there. It's not a big thing, but it is this one. If I have to single out one advantage which is so meaningful to the humanity, is this application of this flex Rexis in anterior and posterior capsule in children. Because if you do both Rexis and if you capture, you don't need to do vitrectomy. That's what we do. I don't do flex most of the time in pediatric because I have to use 2 PIs, so expensive. But if you can do that, now with the principles of optic capture, we published an article in September issue or October issue of last year where we did capture with no vitrectomy and conventional in the bag with vitrectomy. So the flex Capsulorhexis is really a boon, but like the paradox of life, this is where the patients don't have the money. But the thing is that it is easy to perform it under GA, and you can produce a Rexis of your size and your choice, centration and whatever, and you can really do that very well. And the thing is, as I told you earlier, this is a PCCC performed by LensX, and I will not do Rexis, not do anti-vitrectomy, and I will just capture the CP Acrisoft. You can use whatever lens you want under that Rexis, which is through that flex-induced PCCC. So the question is, what you find in the bench or in the laboratory, the strength of the Rexis, the ruggedness of the Rexis. Luckily for this technology, in clinical scenario, it is sufficiently strong to withstand the retractors you can pull it for the subluxated cataracts or capture through the small Rexis. So that is true, and the laboratory science has to be correct. But for a clinician, it is an information. I will keep it in the back of the mind. So that's how the thing I see. And you can do with some opacities. We do a lot of RKs. I mean, some RKs are terrible. You can't do it. But most of the RKs done sensibly or with the pterygium and sort of thing, you can produce that and address that thing. And including if you're an ICL, and you can recognize that ICL there, you can perform that. You can also take advantage while you're performing Rexis after doing that, breaking the IOLs also and make some cracks so that with a small incision you can remove the ICL, which goes through small anyway, actually. So this is the same patient with you saw there, and then you need to enlarge this one because you want to remove that, I mean, more than 2.2, and then you have a choice. Remove that ICL, and then the Rexis. So this can be combined, as I said earlier, with various maneuvers of lens removal and this kind of little thing. I'm doing it with pre-chopper. That's not Rexis contribution, but the technology. So I think if you are affording, or if you think it is viable, and that's the key question, is sustainable in your practice, the patients can appreciate that consistency and a slight safety, this is worth. Well, representation is still an issue, and many times with this view, and there are other machines which give some different views. All of these have some issues of concentration of different kinds, but you can end up with some part cover and not total cover, or just a minimal cover and one, and thing as the side. So what does the literature say? I think there are literature, and Sanjay mentioned that.
Capsulotomy. And in the future, we have a couple of new techniques which are coming in for capsulotomy, and one of them is Capsular Laser. This is still not launched. However, I'll just give you a small peep into what this technology is all about. इसको आगे move नहीं हो रहा यार, इसको play नहीं हो रहा भैया, इसको hello hello, इसको आगे move करो. It's not working. So capsule laser is another laser which हो गया ready? Okay. So it is another laser which gets attached to the operating microscope. It's a very small compact unit, and it works. The principle is that you have to first stain the anterior capsule, and after staining it, that becomes the interface which absorbs the energy and causes the cutting. So you have to stain the anterior capsule with trypan blue. A selective target for the laser is created. This laser is not pulsed but continuous and is scanned in a single circular pattern to create the continuous curvilinear capsulotomy. In the region of the irradiation, the laser energy facilitates the molecular phase change of the capsular collagen 4 to elastic amorphous collagen. So it is changing the collagen 4 to amorphous collagen, and as the collagen undergoes this phase change, it creates the capsulotomy with a rim that has a high degree of elasticity and tear strength associated with the amorphous collagen, which means that the strength of the capsulotomy is again as strong as you would see in a Zepto capsulotomy, maybe even stronger. So this is a Capsular Laser device which is attached under an operating microscope, and on this side is the console, and this is the trypan blue which is used to stain the anterior capsule, and we have prepared the eye. We are putting viscoelastic in the eye, and now we are focusing, the contact lens is in position, and now this is the capsule laser, and it has made the anterior capsule opening. So it is such a clear cut thing into the anterior capsule, such a free capsulotomy that you can just hold it and pull it out. Now the edge appears very smooth in electron microscopy, and it is again a curved and a curled up edge as you saw in a Zepto. See this edge curl? This is also what you saw in a Zepto. The edge is curled up on itself, and that's imparting it the strength. Along with this is amorphous collagen all along here, which also gives it that strength and elasticity as you saw in a Zepto. So this is again showing you the kind of strength a Zepto laser capsulotomy has. You can stretch the capsule to such an extent which normally you would not dare to do. So the results are that there is no constriction of the pupil after the use of this laser, which is often seen in flax. No untoward AC activity is noted post-op. 20 patients with more than 18 months follow-up. This is from the original articles. All corneas were clear. Endothelial cell counts were normal as expected. Capsulotomies were well centered and not contracted, and there was no change in IOL position. So everything looks just nice and fine. A lot of work is going on. And now the next work is going on is to use the same capsular laser for posterior capsulotomy. If you can make an anterior capsulotomy so simple, you can also make the posterior capsulotomy so simple. So it will have a great use in pediatric eyes. And it will be just so simple. So the future for ophthalmologists is getting more and more simple. Note that the anterior hyaloid remain intact even after using this capsulotomy for the posterior capsule. So they are, with this anterior and posterior capsulotomy techniques in position, you can use IOLs which are called bag in the lens IOLs, and that would be the end of having PCOS for the patient for all his life. Okay, now so now there are this is a capsulotomy system I've already explained to you, and there's another device after Zepto which is again in the pipeline and is expected to come in the near future, and this is Aperture Rx. Now this is a very interesting device. So there is, you have to fill up the chamber with viscoelastic and introduce this Aperture Rx through the main opening. The ring opens up, in a microsecond you apply this heat energy or pulse, and it makes a capsulotomy. Then you contract this ring and you just pull it up and use it again. So it will be a reusable item, and it will make capsulotomy very simple and cheaper, because one handpiece will be able to do a number of controlled capsulotomies. So you young ophthalmologists, for the future, it's getting simpler and simpler to make all these capsulotomies. Thank you so much. Anybody has any questions which would you would like to ask? Yeah. First, the lady, sir, in the back. Yeah.
No, this is regarding Zepto.
Yeah.
Two questions. How do you center the thing every time? Are there any guidelines for that? Second thing, are there untoward, unexpected complications like Rexis running off or something like that?
Okay. Do you have a Zepto? Have you had any experience?
No, I have
First
taken
time?
this thing. Yeah, I have.
Okay.
Demo.
So for the centering, when you look at the microscope light, so there are two lights, the right and the left light. So if you want to center, you with the left eye you look at the red reflex or the light reflex on the cornea, and it should be in the center of the cup. So that is the best point to center, and you know, even though your pupil may be irregular or size, but you would get a bang on center in that situation. Now untoward incidents, the only untoward incidents I have seen is 2 cases of those capsular tags. That too happened in hypermature turgid cataracts. So that microsecond pulse did not cut it all across, even though the capsule was in good contact with the nitinol ring, and it would have had the effect of that heat micropulse, but still it did not cut. But it did weaken it from that point. So that means when I used that forceps, I could tear it along the same edge. But again, that edge would not be as strong as a curved edge of a burn. So if the capsule has to give way, it would give way from that point, because that would not be that 2 times or 3 times stronger point than the rest of the curved edge with the Zepto or with the Capsular Laser. Sir, your question?
What should be the minimum size of incision?
For
Zepto.
Zepto, minimum size is 2.2 millimeters. So I showed you in my video, I was using that incision marker, and that incision size was 2.2, and this Zepto went in very comfortably from a 2.2 incision.
Okay. If capsule is fibrotic, or you can say that some calcified anterior capsule is there, does it make a difference?
Theoretically, it is supposed to cut through or weaken the fibrose or a calcified capsule, but unfortunately, practically, I haven't come across such a capsule where I could show my video recordings of what actually happened. The only anterior capsular fibrosis I could show you was a central patch, so it was not really a challenge for a Zepto. I was hoping that someday some patient will come up which will have more extensive fibrosis, and even if I have to do it free of cost, I would do that with a Zepto to see what Zepto could do in such a situation. But yes, theoretically they say it helps a lot.
In how many size that Zepto is available? I mean to say the size of CCC.
Zepto is designed at 5.25, so it opens up to about 5.25 to 5.5, which is technically a little large, because we would prefer an exact 5 mm Rexis, because that would give us a good half mm overlap on all around a 6 mm IOL. Even in a femto laser, when we do with a 5 mm Rexis, we find that the overlap is a little less. I don't know, that was my personal experience. So I started using 4.9 or 4.8 Rexis size to get an ideal overlap of a 6 mm IOL. Dr. Basavada, what has been your experience in this?
I agree totally with you. 4.8 is my choice,
Okay,
but never more than 5.
never more than 5.
Because if you see 6 millimeter, you want some decent curve. The idea is that the whole anterior capsule which lies on the IOL will plaster the lens on the posterior capsule. So it has a kind of a pressure profile. So we need some rim to be effective. Otherwise, it's not worth having it. And it will not maintain that ELP position.
So 4.8 with the femto laser. So Zepto is coming out to be 5.5, so that is not a healthy size. So we've been talking and having meetings with the Zepto people who have designed this, and we've asked them to make a smaller CCC opening so that we are more comfortable. They said they're working on it, but only you Indians have come up with this requirement of a smaller size. All others are feeling very comfortable about it. I couldn't understand why.
Sir, about a long-term follow-up, as far as capsular contraction is concerned, what's about the Zepto?
So far, our series, the period which we have faced is very short. It's only about a year or something. We have not faced any situation of capsular fibrosis the way we would see in a routine needle capsulotomy with a smaller size. But maybe that is because the edge is rounded and the edge size is bigger. So chances of capsular bag fibrosis and phimosis is negligible. Any other question for? I would say that still all over the world, 90% of the Rexis is done by needle. Dr. Basavada, would you agree to that figure? 99% probably. So needle is still the basis of capsulotomy, and these modalities are expensive. So in the Indian scenario, they cannot be used as a routine. They can be used in some special situations. We started using Zepto, and when we had to use them in, say, insurance patients, we have sent special requests to the insurance company that add on Zepto because of this reason, and we are normally using it for, one is white turgid cataracts, so that and very, very hard brown grade 5 cataract. So we say we need an add-on use of a Zepto handpiece, which is disposable. So if it's disposable, the insurance companies are nice enough once in a while to give us the cost of a Zepto, so that works very well. In fact, these days insurance companies have started giving Malignant ring also as an add-on. Sir, have you experienced that with the insurance companies? This is very new. Previously, they used to just fix a fixed package, but now you started saying, okay, in the fixed package, I need to use a Malignant ring, and so they give us an additional cost for the Malignant ring, and in 1-2 cases, they've even given us a cost of the Zepto handpiece. So that was a real new phenomena that has happened recently. Anybody? I don't know. Maybe some clerk sitting there at that level didn't know the difference. This is all over. So with that, I thank you all for making this session successful and such a patient and a nice audience. Thank you all. Thank you, Dr. Vasavda, and thank you, Dr. Rashad. And thank you for bearing with us through if you all haven't had your lunch, and this is still the right time.